Good morning everyone. My name is KEERTHI. I'm here to present a case of right eye traumatic optic neuropathy with internal carotid artery pseudoaneurysm. My co-authors are Dr. P. Ravikiran sir and Dr. Sudhir sir. Here is a case report. A 21-year-old female patient came to emergency department with alleged history of injury due to self-fall at 9:15 a.m. brought to the hospital by an ambulance accompanied by her mother with chief complaint of blurring of vision in right eye since the time of injury. Patient had head injury, one episode of blood vomiting and a nosebleed. History of present illness, patient complained of sudden painless blurring of vision of right eye since the time of injury, associated with headache, foreign body sensation, redness of eye. There are no other ocular complaints. There was no history of loss of consciousness, any ear bleed, seizure, pain and restricted movements of neck, chest pain, abdominal and pelvic pain. There was no significant past history. Personal history, she takes mixed diet, normal appetite, sleep pattern, normal bowel and bladder habits. Family history, nil significant. On general examination, patient is conscious, coherent and cooperative, oriented to time, place and person, moderately built and nourished. Pallor was present, no icterus, cyanosis, clubbing, pedal edema and lymphadenopathy. Her vitals were stable and systemic examination was normal. She had abrasions lateral to right eyebrow, over left upper eyelid, left elbow and both knee regions. Local examination, head and chin position was normal. Ocular position was orthophoric. Ocular alignment was central. Both eye extraocular movements full and free in all gazes. Bedside vision, right eye counting fingers up to 5 meters, left eye up to 6 meters. Coming to positive findings in anterior segment evaluation. In right eye, there was an abrasion of size 1 into 0.5 centimeter at the lateral end of the eyebrow. And there was subconjunctival hemorrhage temporally extending from the lateral canthus to the limbus, and a foreign body stone of size 1 into 2 into 1 mm present in the lower fornix lateral aspect. Pupil mid dilated 5 to 6 mm. Direct light reflex was absent. Consensual light reflex was present. In left eye, there was an abrasion of size 3 into 2 centimeters over the upper eyelid. Pupil normal size 2 to 3 mm. Direct light reflex was present and consensual light reflex was sluggish. Fundus of both eyes was normal. These were the clinical images. In CT brain, there was an edematous intracanalicular part of optic nerve on right side, mild compression of right optic nerve at posterior and superior most part of optic canal or intracanalicular part and proximal most part of the intracranial segment. There was subarachnoid hemorrhage, especially in the basal cistern, and pneumocephalus was noted. MRI findings were similar to CT. The case was examined by a neurosurgeon and the GCS was E4, M6 and B5. Patient was kept on anti-epileptics and antibiotics. My clinical diagnosis was right eye traumatic optic neuropathy. Treatment was administered with injection methylprednisolone 1 gram IV OD for 3 days. The following day, the patient complained of diminution of vision to 3 meters. Color sensitivity was decreased. Right eye optic nerve decompression was advised under guarded visual prognosis. Patient was examined by ENT and head and neck surgeon. Transnasal endoscopic right optic nerve decompression was planned under general anesthesia. A bony spicule was seen between the optic nerve and internal carotid artery. During removal, internal carotid artery bleed was noted. Hemostasis was secured by placing a muscle tissue from vastus lateralis, surgicel and gel foam. Post-op vitals were stable. Post-operative findings, the right eye vision deteriorated to perception of light. Case was examined by neurosurgeon and DSA was advised. In DSA, there was a right internal carotid artery dissecting aneurysm at the level of carotid cave and supraclinoid region. Dissection of right ophthalmic artery was also noted. The pseudoaneurysm in internal carotid artery was treated with cover stent via snuff box. So here was the pseudoaneurysm and the covered stent. Post-operatively, the patient vitals were stable, carotid stenting was done, and patient was kept on anti-epileptics and echosprin. My final diagnosis was traumatic optic neuropathy with traumatic pseudoaneurysm of right internal carotid artery and right ophthalmic artery dissection. Traumatic dissection of right ophthalmic artery was cause for diminution of vision documented in our case. Discussion. Traumatic optic neuropathy follows trauma with sudden visual loss that cannot be explained by other ocular pathologies. It occurs in 0.5 to 2% of cases. Classification can be direct and indirect. The pathogenesis is they're commonly injured at intracanalicular and intracranial portions. It can be caused by primary and secondary mechanism. The treatment options available are high-dose corticosteroids or surgical decompression. Traumatic pseudoaneurysm results from direct injury to arterial wall as seen in penetrating head injuries. These are highly unstable lesions and that may rupture within minutes after formation and remain quiescent for several weeks and manifest with delayed hemorrhage and neurological deficits. So endovascular occlusion provides the quickest and effective treatment.